and I'm absolutely delighted to introduce Amanda Gwee, who's a newly minted group leader within the theme, who's going to be talking to us on utilising antimicrobials better. Thank you.
Thanks, Andrew, and hi, everyone. My group is... Oh, thanks. So my group's called the Antimicrobials Group, and our research vision is really that all children have access to evidence-based and effective antimicrobial treatment. And we think this is a really important area of research because each year more than 6 million children die due to a lack of access to effective antimicrobial treatment. So our research program really focuses on the serious and high burden infections in children, and today I thought I'd just give you a snapshot of some of the domains of research that we're working on. The first one is around improving access and use of existing antimicrobials, and we've done this using modelling of drug concentrations in the blood. So using modelling, we've been able to define new therapeutic targets, for example, for vancomycin for staphylococcal bloodstream infections. So these are the most common bloodstream infection in kids. And before we started this research, we had no idea how much vancomycin you needed in children's bloods in order to effectively clear their bloodstream infections. So now we've been able to define a clear therapeutic target that we can use as part of clinical care. The second program of research has been around improving treatment adherence. So we looked at an antibiotic called cefalexin, which is a drug that we use for bone and joint infections in children. And the problem with this antibiotic is that it needs to be dosed 4 times a day for it to be effective against bone and joint infections. And we know from our clinical experience that children really struggle with 4 times daily dosing. So using modelling, we identified a twice and a 3 times daily dosing regimen that was just as effective, and now the 3 times daily dosing regimen is standard of care and also included in 7 international guidelines. Then the third way we've used modelling is to improve treatment access. So you saw in the video that showed before that scabies is a really important disease, as well as other neglected tropical diseases for which we need ivermectin. And ivermectin, unfortunately, isn't licensed in young children less than 5 years of age. So we did a study in Indigenous Australian kids where we found a dose of ivermectin for children under 5 in whom it's currently not licensed, so that they can access a safe, effective ivermectin dose, and hopefully we can drive the licensing of this medication in this age group. Our second area of research has been around tailoring treatment to each child, and the reason why we've focused on this is because as we were doing the modelling work, we quickly realised that it is really difficult to dose children effectively if we don't take into account all the changes that are happening in their organ function in early childhood. So to get around this, we used digital health and we built our models into a dosing app, and this allows clinicians to individualise an antimicrobial dose specifically for their patient. And then we validated our vancomycin dosing app in a multi-centred trial, and what this trial found was that when we use the dosing app, double the number of children achieve effective vancomycin concentrations in blood. So with standard dosing, 40%, with our dosing app, more than 80%. And at the moment, we're combining all our dosing calculators to form Kids Calc, which will be a dosing app for serious and life-threatening infections that hopefully everyone can use. So our VANC app is already in the therapeutic guidelines. And our last area of research has been around advancing treatment approaches using rigorous trials. And we led the first trial of vancomycin dosing in infants, and we found that continuous infusions of vancomycin was superior, and this is now standard of care at 10 paediatric hospitals. And now we're leading the MRFF-funded BEST trial, which is a trial comparing entirely oral antibiotic treatment to standard of care, which is initial intravenous treatment, and that's for bone and joint infections. And the hope is that if we can treat these infections with oral antibiotics, that children in remote and resource-poor settings will have better access to treatment. And at the heart of our research is always patients and our collaborators. So we've formalised our research network to form the Kids Dose Consortium, which is a network of 22 paediatric clinician researchers across all the major hospitals in Australia and New Zealand who are working together to advance research in paediatric antimicrobials with the hope that one day we can help solve the problem of children accessing effective antimicrobial treatment. And thank you to my funders and collaborators, and most importantly, my research team. Yeah.
So there are mics there for questions, and I should have called before for questions, but so I'm going to ask you one. Yeah. So this is a terrific work of research that's got a clear view to translation into clinical practice. But what's next, Amanda?
Well, at the moment, the World Health Organisation have recently released their paediatric antimicrobial dose optimisation list, and that's in acknowledgement of the fact that access to therapeutics is so far behind in children compared to adults. So our research is now focusing on that, and we're also building other ways that we can improve access. So we're collaborating with Monash, trying to build child-friendly and palatable formulations of antimicrobials for kids. So we hope to diversify our skill set over the next few years. Yeah. Thank you. Thanks.